On today's show, we have Dr. Stephen Ferrucci from Los Angeles, California, talking to us on what's new in retina on the Optometric Insights show. Hi, everyone. I'm joined here with Dr. Steve Ferrucci. Steve, thank you for being here. Really, really appreciate your time. I still remember the first time I met you. It was at the Texas Optometric Association meeting. Saw you lecture on retina. And to this day, it's arguably one of the best retinal courses I've seen. I manage retina out of necessity. I certainly want to make sure I'm doing what's in the best interest of my patients, but I spend a lot of time on ocular surface disease and anterior segment disease. And because of that, a lot of the CE that I even take revolves around that area: anterior segment, advanced anterior segment disease, and specialty lenses. So when we get the opportunity to get kind of what's new in retina in a very clinical and practical approach, it's always great to hear that, and you really deliver on that. And I'll share with you too, I was part of a meetings committee several years ago too, where your name actually stood out as one of the best lecturers, and the comments that always came back were, one, he knows what he's talking about. Two, he's in the trenches actually working and dealing with this on a daily basis, and you can tell immediately based on just how you converse about the topics that you do. So honored to have you here and to be sharing really what's new in retina. So let's get right to it, Steve. Tell us kind of like the 3 or 4 things in retina that we need to either kind of know about right now or that we should be looking for in the near future.
Sure. Well, first of all, thanks for having me, Mile, and thanks for such a nice introduction. I might have to hire you as my publicist.
You deserve it, buddy.
Thanks. So as far as what's new, there's a lot of stuff new in retina. And like you said, I'll highlight a few. But the thing that I think is really cool is that, years ago when I started talking about retina, we didn't have that much to talk about. And within the last couple of years, and it seems like every year, we have more and more to talk about in the retina field. So it's really, really nice and really exciting. But there's a couple of things I'm excited about. One of the first things I'm excited about is it's been around for a while, but I think there's going to be a little resurgence, at least I hope so, is genetic testing for macular degeneration. Mm-hmm. And it's been around probably for about 10 years. There was a company called Arctic DX. They have a test called the macular risk that it's been around for some time, and they've been doing some testing for that. But there's also a newer company out there that I actually am doing a little consulting with by way of, disclosure. But it's called Visible Genomics. It's a newer company based out of Chicago. And they also do some genetic testing for macular degeneration. They do it a little bit differently. They have 2 separate tests. One is a test that's a progression test. So you would run that on a patient with, maybe early or intermediate macular degeneration. And it would tell you their chance based on genetics and other risk factors, such as like BMI and smoking, stuff like that. It would tell you their risk for developing advanced macular degeneration and subsequent vision loss over the next 2, 5, 10, 20, or up to 30 years.
Wow.
And then, you could use that information to sort of tailor your treatment based on that individual patient's risk. So if they're very high risk, you might not want to see that patient back, on a yearly basis, which might look like, if you just looked at their fundus, it might say, I'll see him back in a year. But if you run this genetic test and you find they're high risk, maybe you don't want to give them quite that much of a leash. And maybe you want to see them back every, 4 or 6 months, run an OCT, and really make sure that they're doing okay with the macular degeneration.
That's interesting, Steve. I'll tell you, with the genetics, even in the anterior segment space, we're going to see some testing that's going to assess risk as well too. It's going to be interesting how it's taken in by patients. The 23andMe's now online. There are people that are, they love it. They want all that information. Then there are other people who are just, cautious about all of that, and they'd rather not know for reasons. So again, it'll be interesting to see kind of what the acceptance is from clinicians and also patients as well too on that.
Yeah, I agree 100%. It won't be for everyone. Like you say, there are patients that don't want to know, and that's fine. But at least we have that option that we can give it, offer it to our patients. Yeah. And I agree with you too. With 23andMe and all those things, it's more and more acceptable, every single year. Yep. And this Visible Genomics also has a second test. It's called a lifetime test. test rather, and it's aimed at younger patients, generally 55 or younger, and it's for patients who have maybe a strong family history of macular degeneration that don't have any signs yet, or other risk factors, and it will actually tell them their lifetime risk of getting advanced macular degeneration. And again, you can use that information to counsel the patient, more aggressively or less aggressively, depending on their risk profile. So,
Great.
I think stuff like that, and I'm sure, like you were saying in your field, I think this genetic testing, we're really just kind of at the tip of the iceberg, and I think in the future, it's going to be a big, big deal.
That's great. That's great. What else you got new, Steve, that's kind of coming down the pipe in retina?
Yeah, so, not so much for optometrists, because we probably won't be doing it, but there's a new agent out there that just had some new data released a couple weeks ago. It's called faricimab. It's made by Genentech, and it's what they call a biphasic, or what do they call it? A biphasic, I think it is. Bispecific, rather, a bispecific antibody. So what it is, it's an antibody and it has two arms to it. And one arm is anti-VEGF that we're all familiar with for treating, macular degeneration, as well as diabetes and vein occlusions and myriad of things. And then it has a second arm, which is what they call an angiopoietin-2 inhibitor. And angiopoietin-2 is also very important in eye disease. It increases vascular permeability, it increases neovascularization, and that sort of thing. So the thought is, if we can block VEGF as well as this angiopoietin-2, they call it Ang2, it will be better than what we just have now, which is anti-VEGF. So it's pretty cool. They just came out with I think it was phase 3. I'm not 100% sure, but they just came out with some results within the last 2 weeks at a big retina meeting. And essentially they found that it's better than, it works as good as Eylea, which is another anti-VEGF agent. Works as well, but you're able to inject it less. So, one of the new things that they're looking at with a lot of these AMD type treatments, as well as diabetic retinopathy and diabetic macular edema, is reducing the patient burden. And these AMD things, once you start injecting them, some patients get injected every month, maybe every 2 months, and I've got some patients with bilateral disease. So now they're coming in, we don't like to do, some doctors do both eyes at the same time. We don't really like that, because God forbid you have a problem.
Yes.
You're really up a creek with a paddle.
Yes.
But so this agent, as well as some others that are coming out, are aimed at really giving the good results that we've been used to with the anti-VEGFs, but decreasing the burden on the patient, so they just don't have to come in as frequently.
Yeah, because a lot of these patients too, Steve, I mean, when you think about it granularly on the ground floor, they're usually older individuals, and they're usually individuals that either need transportation or dependent on other people. And again, it's difficult for people to know that they have to be dependent on other individuals for this. So, that's great. That's great.
100%.
Yep.
Yeah. And then along those lines, there's another thing that's kind of cool. And I believe, and you might know this better than me, but they're doing a similar thing in other fields, but it's a port delivery system. So what it is, it's a little implant that's actually implanted underneath the sclera, and it's filled up with, in this case, the studies are looking at Lucentis. So it's filled up with Lucentis, and rather than the patient having to come in, every month for a Lucentis injection, the idea is you fill up this little, refillable port, and it gives them a sustained release of an anti-VEGF agent, Lucentis, over an extended period of time.
That's great.
It's pretty cool. And the studies seem to show that a lot of patients can go 6 months, 90 some odd percent were able to go 6 months without having to refill it. Some almost up to a year without refilling this little gadget. So again, that would decrease their amount of time they have to come in for injections.
Now, this is interesting. Do you potentially, and again, I know you can't forecast or foreshadow this, but this almost seems something that can be even more coordinated care with ophthalmology and optometry, depending obviously on what state laws are and things like that. But I mean, I almost hear this and think this is a way that we can potentially get even more involved with the care of these individuals and patients. I mean, do you see a potential there, Steve, for optometry being more involved in this because of the port system?
Yeah, I think so because if you think about it, these retina specialists are busy, right?
Mm-hmm.
And they don't, at least the ones that I know, they don't really want to see stable patients. They don't really want to see dry patients. They want to see patients when either they need injections or there's an interval change that indicates that they're getting worse. So I think in a case like this, if you were to refer a patient over for treatment, you or I, we could then have that patient follow up with us after they get this port delivery system, do repetitive OCTs. And then if we ever find any change in their OCT, boom, we send them, back to get a refill or another injection or whatever the case may be. So I think you might be onto something. I think it might let us be even more involved in the retinal care of these patients.
Steve, this was awesome. I mean, just to get insights from someone like you on the technologies that we're actually kind of in the midst of right now is absolutely fantastic. Really, really appreciate your time, everything that you do for the profession, obviously for your patients, and certainly joining us here today. It was well worth the invitation, and certainly thank you for giving up a block of your time to share with the profession. And thank you all for being here on the Optometric Insight Show. Make sure you subscribe to our channel and make sure you're listening to the podcast. Thanks, everyone.
Thanks.